answer to first question is definitely yes. If the patient is able to tolerate ARNI, we have to shift all the patients. And when to switch? Whenever you get a patient in your OPD, and he is on ACE inhibitors, he is having a chronic heart failure stage, and he is on treatment, then he comes to you, our endeavor should be to explain to them the benefits of ARNI as compared to ACE inhibitors. Initial thinking with us was, with initial trials, was that if the patient is doing well, he is maybe class 2, then we can continue with ACE inhibitors. But upcoming trials over the years, we have seen that the mortality benefit which ARNI offers over ACE inhibitors is definitely advantage to the patients, and we should try and shift all patients who are on, even who are very well tolerated, I will say, on ACE inhibitors to ARNI. When to switch? So whenever is the first visit of the patient, if a chronic heart failure patient. Acute heart failure is a different scenario that we will discuss going forward. But chronic heart failure patients, once he visits, then that is the time to explain the benefits and then to switch the patient. We should know that the switch, if the patient is on ACE inhibitors, we have to give a cool-off period of at least 36 hours. So for 36 hours, the patient should not take either the ACE inhibitor or ARNI, and after 36 hours of stopping the ACE inhibitors only, the first dose of ARNI should be administered. And should we wait till they become unstable? No, we should not wait. That is the thing that we want to prevent, because we know that with each acute decompensation, the patient will still go further down and his longevity will decrease. So endeavor should always be to shift patients on ACE inhibitor. That is what we do routinely in our clinical practice. So these are the things which just emphasizes the point that 20% of the stable patients in paradigm HF trial, they had a primary event. 17% of these patients, that is during the course of the trial, within 2.5 years. And of the stable patients who experienced a primary event, death preceded the heart failure hospitalization in more than half these patients, and 60% of these deaths were sudden deaths. So this is the importance, that we should not wait for the patient to become unstable. Once we know the benefit of the molecule, we should definitely add it as soon as possible. So ARNI should be started as early as possible and do not wait for the deterioration. So the guidelines say the same. ARNI has been given the most importance, and once patient is not able to tolerate ARNI, then only we should go to ACE inhibitors, and once not able to tolerate ACE inhibitors, then we can go to angiotensin receptor blockers. So acute decompensated heart failure different from de novo heart failure. We can say these two entities are different, but definitely both the entities give us the opportunity to add ARNI, and in both the entities, ARNI is equally beneficial, if not more. In de novo means the patient has come first time, so you would not be exposed to ACE and ARBs, and then you are starting. So you can start ARNI on the even in those patients who are de novo, who have not taken ACE or ARBs previously, and now the trials have conclusively proven that ARNI can be given even in those patients who have not been started on ACE inhibitors. So this is maybe we can define how we can define acute decompensated heart failure. So known population, they already have comorbidities, known ISDs, post-CABG or PCI, stroke, AF, diabetes. These are common risk factors. They have trigger effects such as poor medication compliance, some infections triggering their heart failure, or excessive sodium or water intake and cardiovascular complications or interventions and drugs. Their clinical presentation is mostly with dyspnea, orthopnea, lower limb edema and ascites, and the main pathophysiology is through pulmonary and systemic vascular congestions caused by LV dysfunction. In de novo heart failure, we don't have any previous history. There are less frequent comorbidities. Their triggering events are mostly cardiac ischemias or valvular incompetence, and their presentation is very sick in the form of usually cardiogenic shock and acute pulmonary edema. And the main pathophysiology is definitely acute derangement in their hemodynamics.